The last presentation will be actually my presentation. I hope you all are not so tired. My research interests include geographic racial disparities in morbidity and mortality in the US, multimorbidity in all the adults, and health outcomes in underserved populations. And my presentation today, so I'll try to share the screen. Okay. So can you see the screen? Because
yes, we can.
Okay,
yes,
great. Thank you. So then I can move forward with this presentation. So the title is Disparities in Mortality and Life Expectancy Across the United States: Data, Hypotheses, Approaches, Interpretations, and Facts. This is just the most fresh updated data from December 2020 on life expectancy, and we see that expectancy for both sexes is 78.8 at birth. And we see diseases that contribute most to mortality. So it's heart disease, cancer, unintentional injuries, chronic lower respiratory disease, stroke, Alzheimer's, diabetes, kidney disease, influenza, pneumonia, and suicide. So in our presentation, we also will talk about these diseases. The first part of presentation is about life expectancy in the US versus other countries. This is one of the approaches to understand the mechanisms, the causes behind the differences in life expectancy and other countries, and predominantly other industrialized countries. So here on the left, you can see health expenditure per capita, and that's the most recent data. And we see that in US, it's much higher than in industrialized countries, and it grows. When we will look at the right part of the slide, we see that life expectancy at birth, life expectancy at age 60, and healthy life expectancy at age 60 in the United States much lower than in industrialized countries. So it raises a lot of questions. So we'll try to think what could be behind these findings. Actually, there are several domains in which the US had poor health outcomes compared to other high-income countries. These domains include drug-related deaths, adverse birth outcomes, injuries and homicides, adolescent pregnancy and sexually transmitted infections, HIV, obesity and diabetes, heart disease, chronic lung disease, and disability. For example, if we'll talk about obesity, here is the study in Human Mortality Database and National Health Nutrition Examination Survey. And the study compared the rates of mortality reduction over the time from 1988 to 2011. And on this plot, you see that US, among all countries, and that's high-income countries, have the lowest increase lowest decrease in mortality. And conclusion is that the increase in maximum lifetime body mass index during this time period decelerated mortality decline in the US by up to 0.6% per year. And it means, for example, that it reduced life expectancy at age 40 by 0.9 years in 2011. And we see that annual rate of mortality decline in the US almost twice lower than in Australia. Here is the map of self-reported obesity in the US. And we understand that there could be, of course, geographic disparities in contribution of obesity to lower life expectancy across the US. Because as we see, these maps, the dark red, it's over 35% of population report obesity. And we see different geographic distribution for white population, for Black population, and for Hispanic population. So we need to also account definitely for racial disparities while looking at geographic disparities in life expectancy. And here is the map on life expectancy and healthcare access and quality. And at this map, we see the healthcare access and quality index values. The highest is like lilac, and blue, it's little lower. So we see that while in Canada and most of European countries and Japan and Australia, we see the highest healthcare access quality index. In United States, unfortunately, this index not so high. And conclusion from this study was as follows. Also, the United States healthcare system excels on certain measures. Countries with high life expectancy outperform the United States in providing universal access to healthcare, removing costs as a barrier to care and care coordination. And now let's look what is known from the studies on life expectancy in the United States at state level. One of the studies is on life expectancy in 4 census regions. And the analysis focused on midlife deaths, ages 25-64, stratified by sex, race, ethnicity, social economic status, and geography. 50 states were included in this study. If we will look at this plot, we see the black line, and this black curve indicates US average life expectancy. And we see that green, it's southern states, they have lower life expectancy, and West and Midwest, they have higher than average US life expectancy. The results of this study are the follows. Gaps in life expectancy across the states began widening in the 1980s, so like here, with substantial divergence occurring in the 1990s. And we see this divergence. Life expectancy has stopped increasing since 2014. And major contributors were increasing mortality from drug overdoses, suicide, and system-specific diseases among young and middle-aged adults of all racial groups. Again, if we'll return to the aspect of race and life expectancy, here is increase in life expectancy at best by race and Hispanic origin. And the results show that from 2000 to 2014, non-Hispanic Black have the highest increase in life expectancy, followed by Hispanic, and non-Hispanic white population had the lowest increase in life expectancy. Increased mortality from unintentional poisonings, suicide, and chronic liver disease affected the changes in life expectancy for this population. Primary care physicians, what their role of density of supply of physicians in life expectancy in the US. So this study that used National Center of Health Statistics mortality data showed that changes in cause-specific mortality were associated with an increase in number of primary care physicians. And here on this left side, we see the change in mortality. It's mean that reduction in mortality in case we will add 10 additional primary care physicians. So the result shows that every 10 additional primary care physicians per 100,000 population was associated with over 51-day increase in life expectancy, reduction in cardiovascular mortality, cancer mortality, respiratory mortality. However, from 2005 to 2015, the density of primary care physicians decreased, and programs to explicitly direct more resources to primary care physician supply may be important for population health. In general, based on state-level analysis of life expectancy and geographic disparities in life expectancy in the US, there are several cause-specific aspects. Among these causes are increasing fatal drug overdoses, differences in promotion and distribution of opioids, even overprescription, alcoholic liver disease, suicide, smoking rates, differences in health policies and public health provisions, for example, Medicaid expansion, higher death rates in areas with a history of economic challenges, including rural United States, larger gains in life expectancy in populations with college degrees, demographic shifts like immigration, depopulation, etc., and social protection policies like different social services, education spending, minimum wage laws, economic development, safety net services. So now let's go even closer and we'll have a closer look at county level or close to county level analysis. And let's look at life expectancy in the US from this point of view. There is a classic 8 America study, which actually not a county level, but even they constructed more, over 8,000 counties. It's racial county unit. So we see life expectancy at best, for example, here for white females, and we see the difference on this map almost over 8 years between these areas. And the results of this study showed that disparities in mortality across 8 Americas are enormous. If we will look at figure at the bottom of the slide, so we see that it's about 18 years for males and like 11 years for females. These disparities cannot be explained by race, income, healthcare access, and healthcare utilization alone. And the leading interventions may differ for each region. Also, some common cause strategies may also exist. Another famous study shows associations between income and life expectancy in the US. And they used approach when life expectancy was calculated conditional on income percentile. And they constructed these maps. And for example, the upper map showed life expectancy for bottom income quartile, and map B shows life expectancy for top income quartile. And we see that even within the same income range, there is still huge geographic differences in life expectancy, up to 4 years. This analysis was not based directly on county, but rather on commuting zones, which are geographic aggregations of counties based on commuting patterns, so work routes. And there are 741 commuting zones in the United States. The results showed that higher income was associated with greater life expectancy. Yes, of course. But however, life expectancy substantially varied within the same income quartile. And what is also important in this study, they concluded that differences in life expectancy between same income areas correlated with area-specific health behaviors and local area characteristics. And if you will look on the left, you will see correlations between life expectancy in the bottom income quartile. And that's mean decreasing life expectancy factors, decreasing life expectancy. If you will look on the right, so that will be correlations between life expectancy in the top income quartile and local area characteristics. And you see that while some characteristics like health behaviors, they have almost the same impact for low and top income quartile, other factors differ substantially, and there are even more factors such as access to healthcare, Gini index of inequality, unemployment, percent of immigrants that impact life expectancy in the top income quartile. Another interesting study is on county level mortality rates for major causes of death. And it's also mortality, National Center of Health Statistics mortality database study. They used here approach garbage code redistribution. Garbage code is an intermediate or immediate cause of death rather than underlying cause of death, or a code that is insufficiently specific. For example, disease of other or origin or ill-defined sites, something like this. And as you can see at this plot, upper part, red, it's garbage codes. And then they done redistribution of these codes. So at the bottom, you see to which diseases these codes went. And we see that most of these garbage codes went to cardiovascular diseases and also to diarrhea, lower respiratory, and other infection diseases. For mental diseases and neurological disorders, so these colors, we see that the difference was not so substantial. Further mapping of the results after this redistribution of garbage codes showed that there are hotspots, disease-specific, in the United States. For example, these are areas with highest age-standardized cancer mortality. These areas with highest CVD mortality. For neurological diseases, we see like multiple hotspots. For chronic respiratory disease, we see Appalachian area hotspot and some other spots. So these areas have extremely high mortality from self-harm and interpersonal violence, and these areas from mental and substance abuse disorders. And now we will move to the study of our group. So let's start on geographic determinants of morbidity and mortality in the US. And there are counties which are red, so-called leading states by the life expectancy. So these counties have, these states, sorry, they have the highest life expectancy. And lagging states, they have the lowest life expectancy in the US. And this life expectancy difference is true for males, females, for white and black population. If we will look at disease-specific contributions to life expectancy at age 65, using multiple cause of death data, we see that disparities in the lagging, between the lagging and leading states, they're changing over time. So we see like the role of myocardial infarction goes down, but COPD goes up, and Alzheimer's disease, for example, goes up. So this like percent of contribution from each disease contributing to the differences in life expectancy in the US. So diseases you see here, they're most contributing to the difference on geographic scale. And if we will compare race-specific disparities in life expectancy, we see that over time, the difference is smaller, but geographic disparities become wider. And it's true when using both multiple cause of death data and also Medicare data. And what is also important to state that while using Medicare data instead of death records in death certificate, like in multiple cause of death, we use incidence-based mortality, which is defined as mortality that occurred in patients with certain disease after they have been diagnosed with this disease. And this incidence-based mortality allows a partitioning of mortality by variables associated with disease onset and progression. And we had in the morning, Dr. Igor Koshevich presented a presentation on the partitioning of mortality. So differences in disease incidence between the leading and lagging states based on Medicare data. So green diseases within the green circle, which have hazard ratios over 1.3 as contributing to the differences in incidences between two groups of the states. And we see that it's pretty close for females and males. If we will go to the survival and diseases which survival differences in survival contributes most to the differences between the states with the highest and lowest life expectancy, we will see that these diseases, the list looks different from the incidence. So, for example, if incidence diseases marked with green and survival contributing most from survival diseases, they're marked with red. So we see that there is no crossing between these two groups of diseases. Also the same we see in survival. What does it mean from practical point of view? That means if we're thinking to improve the strategies to reduce the differences in life expectancy between the states in the United States, we need to pay attention at certain diseases with specific focus on diseases which have the contribution because of the differences in incidence rates. But for other groups of diseases, we need to pay attention because of much lower survival in the lagging states, for example. So it requires this comprehensive approach. Very important information we can get from remaining life expectancy. For example, we used 5% Medicare to calculate remaining life expectancy at age 65. We used Cox model to investigate the effect of residents in the lagging and leading states on total and remaining life expectancy. And remaining life expectancy was calculated based on the records on disease onset and deaths. For example, here for myocardial infarction, we can see that for total life expectancy, these two lines, the upper is in leading states, lower is in lagging states. And myocardial infarction means that person who had myocardial infarction had life expectancy like showed here, respectively in leading black dots or lagging white squares states. What can we say about remaining life expectancy? On this slide, we see myocardial infarction, heart failure, atherosclerosis, cardiovascular disease, and cerebrovascular disease. And on next slide, we also have lung cancer, breast cancer, prostate cancer, colorectal cancer, pneumonia, influenza before COVID, Alzheimer's disease, dementia, diabetes, renal failure, and sepsis. And if we will look at these graphs, we can tell that remaining life expectancy was the shortest for lung cancer and sepsis, following by Alzheimer's disease, dementia, pneumonia, and heart failure. So these diseases take the most of life expectancy from population age 65. Between the states, differences in remaining life expectancy were most pronounced for cerebrovascular disease and atherosclerotic heart disease, also for breast cancer, prostate cancer, and the difference was less pronounced for heart failure, lung cancer, pneumonia, and sepsis, diseases which have a very low survival rate. So it's understandable why the difference was less pronounced. Time trends of remaining life expectancy decreased over time for myocardial infarction and slightly decreased for cerebrovascular disease, and increased substantially for renal disease, renal failure especially, diabetes, atherosclerotic heart disease, breast cancer, and prostate cancer. Here is example on heart failure as one of diseases which contributes most to low life expectancy and to the differences between the states in life expectancy. So we use CDC Wonder mortality files for figures that showed heart failure mortality trend. And we see that initially it goes down and then it goes up. Then we use 5% Medicare claims to look at survival. And we see that 1, 3, and 5 year survival initially goes up and then started to go down. And that's some alarming trends in mortality from heart failure and survival of patients with heart failure. Also, partitioning analysis showed that the decade-long decline in heart failure mortality was mainly due to decreasing incidence, while recent increase of heart failure mortality was mainly due to decline in survival. And it's a point for discussion, but hospital readmission reduction program that put penalties on hospitals with higher than expected readmission rates could potentially contribute to declining trend of survival of patients. So geographic disparities of incidence. It showed that Alzheimer's disease incidence rates varied considerably across the United States, both before and after adjustment for social economic health, access to health services, and quality of services factors, with the highest observed rates of incidence in the areas of Midwest and South, particularly in the rural areas. But the conclusion from this study was that the statistical models explain little of such geographic variation. And this is county-level analysis performed by our group. So we used multiple cause of death data here. And we see that the cluster of hotspots, counties, hotspots in Washington state with the highest mortality from Alzheimer's disease versus the lowest mortality in New York state. If we will look at the state specific trends, so we see that over time, the differences even became wider between New York, for example, state and the state with the highest Alzheimer's disease mortality. And if we will look within specific diseases contributing to these differences, we can see the following very interesting finding that it's disease-specific contribution. For example, in this table, these numbers, it's percentage. Negative numbers are for cause-specific mortality that is higher in New York, positive higher in Washington. And we see that, for example, Alzheimer's disease, definitely it's the most contributing disease between the state difference in Washington, especially in white population, especially non-Hispanic, and especially in skilled nursing facilities. While in New York, we see that atherosclerosis, heart disease, the most contributing to this difference in white, black, non-Hispanic population, especially in inpatient, and also inpatient in skilled nursing facilities. We also see some other diseases that have negative numbers or positive numbers. And while looking at these numbers, we can say that stroke, Parkinson's disease, vascular dementia, and falls could share some risk factors with Alzheimer's disease, which is biologic, it's possible. This is why they have the same positive numbers and contribution into the difference between mortality in these states. So, summary of this presentation. Data. So we can move from the cohort studies and multiple cause of death data to Medicare data and health retirement survey study and market start research database, etc. So approaches we can use from empiric analysis and Cox logistic regression to partitioning analysis and other advanced methods, including forecasting approaches. Interpretations from a higher disease rates in certain geographic areas to interrelations of disease patterns with clinic-related factors such as screening, treatment, diagnostic approaches, social economic factors, behavioral characteristics, and potential analysis of impacts of health policies. And important aspects of data analysis is in coding practice differences, increasing prevalences of Medicare Advantage, and private insurance among patients age 65, which is growing over time. It's now almost 30% of all the patients have additional coverage. And coding intensity problem. So even CMS created coding intensity adjustment factor to account for the differences in diagnosis coding patterns. Contribution of disparities at younger ages, younger than 65, for which market scan research databases and other data sets could be very useful. Race misclassification and immigration patterns. And notes about further progress. So it could be useful to perform analysis of surveys with individual level data on social, economic, behavioral factors, genetic characteristics, for example, as HRS data, analysis of Medicare records linked to multiple cause data to study how mortality patterns observed in multiple cause data can be predicted by incidence-based mortality, how competing risks from certain diseases could contribute to causes of death recorded in death certificates. Medicare records used for partitioning analysis. Medicare records used to track the health status of individual involved in cross-state migration, and treatment effects analysis using Medicare Part D, analysis of the role of multimorbidity in disparities in life expectancy, and analysis of access to and quality of care. So I would like to thank, yes, sure.
So thank you for presentation, very interesting review, very interesting results. So as I understood you from your review, that social economic factors, the role of socioeconomic factors in generating disparities could be overestimated a little. And this is in contradiction with the opinion of our audience. Our audience believes that socioeconomic factors, we just had a poll, so they believe that socioeconomic factors is the main factor generating disparities. Could you please comment?
So that's a very interesting question, very important question, and that's actually future of next years of research, because if analyzed per se, social economic factors, of course, very important and they contribute a lot. But if we will look at quality of medical care, access to treatment, treatment adherence, treatment choice in these populations, availability of certain diagnostic procedures and treatment. So we see that this part is also contributes substantially. So I cannot tell that social economic factors are not so important, but I would like to tell that for addition to this factor, as we see, there is still variations in life expectancy, even in populations within the same like social economic characteristics. So we really need to go deeper. And for example, like Medicare provides us such opportunity to look at treatment options, to look at medications, and to investigate this area. And definitely this area also could be linked to the social economic factors.
Thank you. And another question. It's interesting, you reviewed a garbage code redistribution study. So we know that there is a difference between Medicare patterns, disease-specific patterns, and multiple cause of death disease-specific patterns. Before, I thought that the differences in Alzheimer's disease could be because of these strange codes, like authors mentioned garbage codes. So, but you demonstrated us that this is probably not the case, because pattern of Alzheimer's disease was not changed after this redistribution. Is it correct understanding?
It changed, but a little bit. Of course, the most changes we see in cardiovascular diseases. And of course, for addition to so-called garbage code problem, it's always good to double check. If we'll have such a study, it's always good to double check for garbage coding again, specifically for certain disease group. But also there are other problems with coding, which I briefly mentioned in the last two slides, that there could be not actually the diagnosis we see like in medical records or in death certificate could be not actually what's happened to the patient. So it's not like garbage code problem. It's problem of overdiagnosis or underdiagnosis or diagnostic approaches they used, cognitive tests they used, and in general, like this aspect. So of course, we need to pay attention to this aspect. Yeah.
Don't you have explanation why we have different disease-specific patterns in two data sets?
You mean multiple cause of death?
Yes, and Medicare, yeah.
And Medicare.
Yes.
So we're talking about mortality, for example.
Yeah.
Because of course, again, we need to investigate it in more details, but if it's incidence-based mortality, so what does it mean? It means that the patient who had diagnosis, for example, Alzheimer's disease diagnosed, and then this patient will die, and we don't know the reasons this patient died. So it's a little bit different situation. It's like mortality of patients with certain disease. Rather than in death certificate, we don't know, for how long this patient had this disease, and we just see the underlying, for example, cause of death. So, of course, next step, and as you know, our group now, we are working now on obtaining the data and starting analysis on pool of mortality records linked with Medicare. So, and then probably we can analyze deeper what are the sources of differences between mortality, multiple cause of death data set and 5% Medicare. And as I understand, it differs for different diseases. For example, it's the highest difference for Alzheimer's disease, but the difference is much smaller for some other diseases. But right now, I hope in 1 year or so, we can answer this question with our own results while comparing medical records linked to Medicare.
We will have next year meeting. Will you present the results in 1 year?
I'll be happy to do this. Yes, I'll be happy to do this. Mm-hmm.
Thank you.
So thank you for your questions. And I think we can make closing remarks. And I'd like to thank all presenters at this session for their very interesting presentations. And we do not have special discussion time at the end of this session. So if you will have some additional questions, we can discuss tomorrow at round table, and you can get answer to your questions tomorrow. And would some of other speakers like to make their comments now, or we can, wrap our session, or somebody would like to comment the session? Okay, I think it's okay. So then thank you again for all presenters. Thanks for the audience, for your patience, for your interest. And I hope we'll meet tomorrow at day 2 of our conference. Thank you very much and have a nice evening. Bye.